Good morning and welcome to our session number 24 of the ccclivecases.org. I am Samir Mehta, your moderator, and if you notice any change, yes, we are in high def streaming today. Anu and Samin, good morning to you, and you must be exhausted after doing the 14th live case symposium.
I would say a little more energetic.
Samin,
for the next year.
Samin, 20 exceptional cases, including a wonderful TAVI transmission from Italy. What else do you think were the highlights of this symposium?
I think if I had to just put it in a very simple 2 sentences, that Stents has become very simple. Everybody does it, great results. There are few cases where you need little expertise and technical tips. Those are bifurcation, total occlusion, and left main.
But you didn't stop there. I thought there were several quadrifurcations also.
Yeah,
no?
That's the left main quadrifurcation, that how to make that as a bifurcation by cutting balloon rotablation and put 2 stents. So those were the highlight, and I'm sure I got a lot of good feedback on the evening boat cruise that we highlighted the technical details so that the participants who were there could take it back and use in their practice.
What was the feedback from your interventional fellows course?
That's another phenomenal on Saturday, and clearly will continue to increase with the excellent faculty, and we are going to send the CD-ROM of all the presentations, and that has been a very plus point, particularly those who are the first time taker or recertification, and every time they say that almost 40 to 50 questions which we discussed came into their exam.
Samin, 20 genuinely complex coronary interventions, no complications?
Well, I always tell everybody that, it's a little too bad. One thing we cannot teach you on live, that complication, although last year we did have one complication, that was perforation, and follow-up that case was presented this year, how the patient did over the year. But majority of the time, idea is that yes, complication will occur in our field, but if you do a right technical steps, technical points, the chances of those complications will decrease. And towards the same, to keep that theme in our live monthly webcast, starting next month, I will ask, actually, Anu will make a slide after the case presentation that what could be the challenges, 5-6 challenges of the case and how they should be solved. Project means not hindsight, not that we'll face them and we are going to deal with them, so that we'll have a one incorporation of the slide after my case presentation, the technical challenges as perceived by the operator, the key operator, which Anu being trying to teach, that these will be the 4C we expect the problems we'll see in the case, and that is how she's going to deal with them.
I think that is a fantastic idea. Anu, I noticed your mother was in the audience when you were doing live cases at the symposium. How did that feel, and what do you think were the highlights of the symposium from your point of view?
I think it's a good thing to have your parent watching you, and more important is what they feel about you. She has heard a lot about me back home in India, and now she had a chance to see and what other people thought about her daughter. I think for the symposium point of view, I think we always made a point, both for the junior faculty, the fellows, and sometime even the senior people with multiple discussion, that how do we handle the case, means always there's a faculty discussion, how it should be approached, and then how could we do it in a simple way, means you have the steps 1, 2, 3, and that's the way we do it, and you come out with a good result with the same steps. The important thing is you think ahead and do the same thing all the time, so to get the excellent result.
I think that is well stated. Congratulations, Samin, also to Dr. Prakash Krishnan for doing his vascular case, which I think also went extremely well.
Perfect.
Samin, take us through what you have in plan today. Also, one more announcement for our viewers, that the entire monthly webcast can also be seen on the iPad application, which you can download on the iTunes.
Okay. And also that those, if we actually now 23, and this will be the 24th, but all 23 cases which have been done, then if they need people want, they can send us the email and we'll mail them the flash drive containing all 23 cases with our case history, slides, and the entire performance of case, so that yes, you can always go to the archives, but we all have another tool to provide to our participants that they can just send us the email, and we are going to send them the disk, the flash drive.
And
also,
that includes the entire unedited case.
Unedited case, completely unedited, exactly with the discussion, question, answer, which were asked later on, and so. And what I'm going to do next month, which will be after start of the third year, that pick 5 important feedbacks which have been given to us about the symposium, and I think those will be the good to highlight for everyone to know that where we are, and clearly it has been a tremendous success over the last 2 years. Now with that note, I think we can go to the slide quickly, knowing that it's a very complex case, will be a lot of technical, so that I just want to take you through. This is the case, 88-year-old male who presented on May 10th with rest, chest pain and shortness of breath. He ruled in, had a non-STEMI, and had 3 vessel and left main, done outside. Syntax score was 44 with an EF of 20%. Patient was transferred to the surgical service to undergo CABG. But because of the surgeons felt that patient has many high comorbid conditions of COPD, peripheral artery disease, CVA, and the diabetes and poor ejection fraction, they were reluctant to do surgery. So this case was referred to us by the surgeons that if we can do a percutaneous intervention to this elderly gentleman who is otherwise viable, yes, there is no deficit from CVA point of view. So that time with a 3 vessel, culprit being the RCA, that was a very thrombotic but calcific lesion. Anu did a Rota stent of the RCA, patient was discharged, then brought back for intervention today on maximum medical therapy, which is listed below. Now basically we'll go through quickly with the angiogram, very high syntax score. As I mentioned, rightly go for surgery, but this particular case, we will just show the true angiogram. And now today is for the LV diagonal bifurcation. In preparation, patient also had a PTA for the left common iliac artery, which we diagnosed after, was not diagnosed originally in the cath, but we diagnosed after during our first intervention. So Anu, take the angiogram. Yep.
Yeah, so
yep.
This is his left iliac. I think you can see the part of the stent there, which had to be done before we could do this procedure. We definitely need a LV assist device in this particular case. If you see, the EF is close to 20%, and this is what is angiogram. The right coronary artery, you see the stent, that was a calcific thrombotic lesion, and this is another challenge, that when you have both, how do you handle this, that you can do rotational atherectomy but a small burr with a slow speed, so that you get a good expansion and you are able to stent it.
No, obviously you didn't think that the distal of those lesions was significant
yeah,
in the right coronary artery?
It was moderate disease, and we left it alone. We took care of the most significant was 95% disease in the mid, the rest everything we left it alone. And here you have some moderate left main, high lateral, and then you have circumflex disease, as well as I think there's a total occlusion of the LPL. But if you see this LAD, you have a proximal LAD where you see moderate calcium, and then a mid LAD, and then there's a lesion in the distal LAD. Also an important vessel is a moderate to large size diagonal that is involved here.
No, did you think the ostium of the LAD had some significant disease too?
Mild, not if you see in the caudal picture here, is okay.
Yeah, it's okay.
All right.
Yeah. All right, with that note, now question then quickly comes on this particular case, that could we do this case without assist device? But you saw the ejection fraction, and the appropriateness clearly fits into despite not having non-STEMI, because once you are non-STEMI, appropriateness criteria does not apply, because those are appropriate. All patients, because that's what the last presentation of this patient was. And we are going to talk about the LV support during PCI, and I will pause in between. And support basically means, when do you need the support? The person like this, low ejection fraction, and you're doing a complex intervention. So that is a combination. The combination of the low ejection fraction as well as the complex PCI, whether multi-vessel disease or unprotected left main or single vessel supplying or simple bypass graft. Very important is the vein graft. And of course, that you need patient has a borderline hemodynamic compromise, patient with a large MI, cardiogenic shock, and any cath lab catastrophe, left main dissection, coronary perforation, and so those all will require basically the intervention or some assist in these particular cases. And of the three balloon pump, PTVA, and Impella recovers, knowing that each has their own advantage and disadvantage. Balloon pump a little simpler, Impella in between, tandem heart is a little more complex. But Impella is very simple, easy to do, and this is what we have selected in this particular case. And Anu will just show the steps before I go on with my subsequent slides.
Yeah, so we already have a 13 French peel away sheath. That's because the motor of the Impella, we have this newer Impella which is being shown here.
Anu, how long did it take your cath lab people to set it up?
Oh, this one was about 3 minutes, Pablo.
So that
less, he says less. So it is quick. The thing is, it's color coded. So it's easy. How to connect your catheters to right place.
All I can tell you is for the door to balloon STEMI cases, that clearly is a big advantage.
And what modification they have done, you have a 6 French pigtail, and this is where your motor is. What you have is an orange feeder. If you know, in the past, one of the most challenging portion for the Impella was once you are trying to get it over the wire, you had to hold it in a right position so that the wire exit comes out at the right part where you see the marker. But now, since you have the orange feeder, you can easily put it over their 0.018 platinum wire so that it comes out here. And once you do that, you take out the wire and you are able to then insert the whole Impella device. And next important thing is the console. If you can show it, it's an automated and integrated system. There is no need for a pressure bag. What you do is, like Pablo is showing, you just take any kind of a dextrose bag and you just connect it into the system. And I made a comment, as long as you can read English, the system will tell you what is the next step, and a very fast and a quick way of preparing the whole Impella catheter.
Great. And that key is that this easy access quick setup to me saved about almost 5 to 6 minutes of the procedure.
I think that is absolutely critical. Samin, any concerns about placing assist device in an 88-year-old?
Now, that's an important challenge, knowing that this patient already has a peripheral vascular disease. If it was a younger person, I think with this new system, what you can do is just take out this orange peel away and go through the catheter like you would have gone with a pigtail, and very easy, you can just get it into the ventricle. Knowing that this person has peripheral vascular disease, that there is some calcium and tortuosity in the iliacs and the aorta, we will have to use a wire to get the Impella into his body.
Anu, how compulsively are you ruling out LV thrombus and significant aortic valve disease before using the Impella?
Has 100% means during our diagnostic, though we do it with our 6 French catheter, the diagnostic JR, we still are very clear that there should be means again the recommendation is same, as long as your valve area is less than more than 1.5. They are talking about moderate to severe AS. Even in mild AS you can use it, but same about moderate to severe AI you cannot use it. But very important, LV thrombus is important. As long as in your LV angio, that suppose it is an emergency situation, as long as in your LV angio you are sure there is no thrombus, I think you still go ahead and you can place this catheter.
And as you know, there are a couple of reports now about using the Impella during balloon aortic valvuloplasty, which you'll say won't make sense, but it definitely has been done just to give a little extra support. Okay.
And other important is you need to have a good end diastolic, left ventricular end diastolic pressure in this patient. Once we know they have LV dysfunction, many patients are dehydrated, in the sense Lasix, this patient actually had a EDP of about 15.
Okay. Now, if we can just go back to the hands again, that now she is Anu is advancing the wire, and there is a peel away sheath or this red that it will automatically come out from that end hole, because many of them you can do directly, but this help.
It's coming out there.
Take it out now.
Yeah.
Good. See, this helps. So now even another, which was a little tedious for some people, but so that way to will exit out, but now it's kind of a foolproof. So that
I tell you, simple modifications, but such a major enhancement.
Absolutely.
And increasing the speed. Anu, how much do you think is the learning curve with the Impella device? What do you
think you can see insertion of one, and you can do the rest.
Yeah.
See one, do one.
That's
All
it.
right.
And that actually helps in the case of emergency, so you don't have to worry about where the hole is coming, where the wire is coming, and so on and so forth.
So the real challenge is to be having the suitable iliofemoral anatomy.
Yeah.
And now you can see how we are going up. You have a little bit, yeah, maybe because of the stent there.
Yeah, the question is whether the stent there is obstructing our way.
Now, are you twisting or just advancing here?
I'm just advancing, twisting both.
You're holding the wire also, right?
Yeah.
Could the wire would have gone through the stent struts there?
No,
Or should we go from the left side?
maybe
to
you
the
go
stents?
from the left side.
Although it was actually Prakash Krishnan suggested that we should go from the right side and not from the left side. What is happening? You're holding the wire, or I want to hold the wire?
You know, not convinced about the struts there.
No?
Yeah. I think get us a long sheet, no, Pablo? Yeah. 13 French long sheet. So this curvature is negotiated by the sheet, and then we can go with the Impella now.
Okay. Sameen, in the meantime, you want to start your...
Okay, good. Now let's go back to our slides. And while we are just changing it, basically, that off, as I mentioned now, there is no true comparative trial of the tandem heart and Impella. We were the first one with our two presentations, one in JIC and then ACCI to Summit in 2010, comparing our first 20 cases. So that just to be fair, taking the learning experience together, first 20 cases of tandem heart, first 20 cases of Impella, we presented, and as you can see, what we are doing at present is more complex cases, more patients with a lower ejection fraction being done with the Impella compared to PTVA which we had. And overall procedural success was fantastic, and every patient we implanted and explanted in the cath lab. None of the devices were left out of the cath lab, everything was done in the cath lab. What did we find? And this to me is the key slide. That is basically your procedure time, implantation time, you decrease in half. Very simple. Implantation time is 4 minutes because of this quick setup, and the actual after the setup, what time it took for implantation. Total procedure time is just about half compared to a tandem heart, and more importantly, the short and long term results of this 20 cases. The overall length of hospital stay 2 days, vascular complications. We actually have 2 hematoma and 1 pseudoaneurysm, in the one of them being in the Protect 1. Remember, in Protect 1, they made it that we could not have used closure device. So we had to do a manual compression, and that patient had a hematoma and pseudoaneurysm. Overall, from the 30-day MACE, it's shown there, identical, and freedom from MACE at 1 year. The death rate, of course, these patients do die, many of them for various other reasons, but overall 80% the survival rate at 1 year in these tough cases is really remarkable. On top of it, what we have done now, our all cases of tandem heart and Mount Sinai, which is how many numbers? Right? 47? Yeah, 32, and the Impella cases? 36. Yeah, 36 Impella. So this was about last year, the 32 and 36 all cases. We actually have paper has been put, was submitted to CCI, accepted. It's available online at the PubMed ahead of the print. Although I thought it is going to come out in July, but apparently July edition already have come out and it's not there. But it's available on the website with entire experience, extension of what I have just shown, and we put all our cases together. Nutshell, Impella being used in more complex cases, but without any penalty in terms of complications of whether ischemic or the vascular. Now this actually, while Anu has just put a long sheet and we are going to go through in next 2 minutes, so that let me quickly finish the Impella issue, and that is the Uspella registry. Last we showed in our November webcast, overall seems to be in high risk patients that your overall MACE rate is about 8%, and the similar was in the PROTECT one, and it showed basically that you improve the ejection fraction by 17%. And similar in the PROTECT one and the other Italian registry, and you bring the patient, majority of them become class 1 or 2. So clearly the Uspella, which in the acute MI as well as in the high risk patients, there are data available. More important was the PROTECT 2 trial. PROTECT 2 trial was the randomized trial of the balloon pump PCI versus the Impella PCI, high risk patients who will require prophylactic hemodynamic support during non-emergent high risk PCI, which they define as unprotected left main or last patent conduit with EF of 35% or 3 vessel disease and EF of 30%. And the primary endpoint were composite MACE major adverse event at 30 days with second is continuation of primary endpoint at 90 days. So MAE at 30 days and 90 days were the primary endpoint. Now, just to say, in the trial, because these patients develop various complications, the major adverse event was a composite of numerous events. That is the death, MI, and MI was defined as CKMB of more than 3 times, then stroke TIA, repeat revascularization, cardiac or vascular operation for various issues, and then acute renal dysfunction, hemodynamic, the increase in aortic insufficiency, severe hypotension, and VT and CPR, and basically the angiographic failure. So those were the composite of these 9 endpoints combined was the 30 and 90 days as a primary endpoint. Now you remember that last December with the 30-day endpoint in the 305 cases analyzed and data monitoring safety, this was a pre-planned interim analysis. Recommendation at that time was made by the data monitoring safety committee that analysis of 30-day endpoint of 300 plus cases, they found that there is no reason to continue the trial longer and was suggested to stop the trial. Now why did this do that? Basically that right here that patients 38% Impella event rate versus balloon pump 43 with a p-value of 0.40 at 30 days, and of course they're largely driven because of the atherectomy group, which was in a small percent of cases, in that to 12% higher event rate, and largely because of non-QAMI and high CK release. But basically the suggested data monitoring safety DSMB recommended to stop the trial because futility of the Impella device even if the trial completes, without realizing that they did not have, without analyzing, I would say the 90 days. So the trial was completed or stopped at that time. By the time 400 plus cases, and this is where the entire enrollment of the trial, that basically the 400 plus patients were being enrolled, and now we have the data on 400 plus cases with a 30-day and 90-day endpoints. Now basically these are the characteristics, high risk again. More importantly, the procedural difference, and this is one of the issue happens when you have open label, and that is what we taught everybody. Use Impella, try to open as many as vessels possible, use as complex intervention possible, and that exactly happened. Balloon pump in 200 plus cases and Impella in 200, that you have a rotational atherectomy just about double, as well as the vein graft intervention. The more aggressive rotational atherectomy was done in Impella group, and this basically, these are the major adverse event, 30-day and 90 days, as you can see there, that overall intention to treat and per protocol. Clearly the per protocol is the number of patients who receive the device what we're supposed to. And you can see at 90 days, there is a significant difference from 51.4% to 40.8%. The absolute reduction of about the 11%, which became statistically significant at 90 days. And if you go to the individual endpoints, which are shown here, And basically, the big difference came in the repeat revascularization. That overall as a group, even the MI was not different, but as the repeat revascularization was significantly lower in the Impella group compared to a balloon pump group, and largely because we were more aggressive, complete revascularization, and patient did quite well, as shown here. As I mentioned, that per protocol with the analysis showing significant difference. Now, then the 90 days, and the 90 days data are here without atherectomy and with atherectomy, and basically you can see the difference basically was the larger high incidence of non-QAMI, which was defined at MB of more than 3 times, which was much higher in the rotational atherectomy group, but at the same time, excuse me, even in those patients, there was significantly lower revascularization, was 1/10, 30% versus 3%. So that yes, you did have paid little extra price of a high CK release, but did not translate into any mortality or bad outcome. Rather, patients did well at a follow-up of 90 days. And of course, if you take a true definition of MI, and as you know, in Mount Sinai, we call it a large MI is MB of more than 8 times. You see there is the difference of the even of the CKMB disappears, and of course the benefit of decreased revascularization sustains. So clearly that yes, the trial got a little negative endpoint because of early premature termination. We always feel bad about it, but if you get into the data and you wait for the 90 days, the story is totally different. And these are the endpoints, IABP and Impella. You can see per protocol population with the MACE that's significantly lower in the Impella group compared to balloon pump group, and these are the with patients without atherectomy. And very important point, and you ask about the learning curve, that there is some learning curve. You see the red bar is the balloon pump and Impella being in the blue, that in the Impella group event rate decreased with time. Again, that was not factored by the data monitoring safety committee, DSMB. And largely the cost wise, that despite the additional cost of the Impella, almost 15,000, I mean 19,000 more, that overall the cost saving, this was presented in ACC this year, that there was $19,000 saving using the Impella device, and that occurred largely because of the decreased subsequent revascularization. So the overall, if we sum it up, that overall the trial was positive and particularly and supports the use of the device in high-risk patients. So now if I had to just sum up that how do we use these cases for various patients with a good ejection fraction, I think complex case balloon pump is good enough. In a complex, the EF of 20 to 35, we had this trial of the balloon pump versus Impella Protect 2 clearly showed that without rotational atherectomy, there is a clear-cut benefit with Rota, little high CKMB, but definitely lower revascularization, and patient with a lower ejection fraction, like this patient 20%, in my opinion, with the complex or even simple PCI, even if you need it for few seconds, that Impella comes very handy over PTVA. Now, you're ready?
Samin, excellent review. Anu, what progress have you made at this time?
Yeah, I think one of the important challenges in this, the question that you had previously asked, that in elderly patient, do we think Impella insertion would be challenging? Yes, it could be challenging, but as long as you know that you predict that there could be a challenge and have your tools ready. So with their peel away sheath, we knew we had trouble in negotiating at the level of the distal aortic bifurcation. Actually, we have done Impella in 2 situations where patient has had the stent graft, the Y stent graft. It has gone through the Y stent graft without any problem, but here because of the heavy calcium, look like we could not negotiate. If you can show the cine, if you see here the Cook.
Yep. Yeah.
This is a Cook sheath that is except that is a 16 French that we have, and the length is 38. Right, and this is a 16 French, 30 centimeter Cook, and what important is that it has now completely straightened the distal aorta. If you see here,
yeah,
all that problem that we had with the negotiation has been taken care with this sheath, and now we have the Impella ready for insertion.
Good. We are going to do the Impella insertion, then I'll go to the second point quickly.
Yeah.
On the
and also, I think the Cook comes with the 14 French sheath also, which we could use. Yeah.
But why did we not use 14 today? Yeah, okay, because part of that, these things we use in our, as a part of the TAVI.
Yeah. So now, if you see that as you're going in.
No problem whatsoever.
Yeah, no as you're going in, and very important is if you can see the marker, and that marker, if you can see, that is a new thing, it's about 4 centimeter below the annulus, and the elbow should be at the level of the annulus or the valve. And as soon as you're there, you take out the wire, your console will tell you, this looks good. Yeah.
Show that console again.
Anu, do you have Swan GANs in place also?
In this case, we do not have it because we just clinically, we just go with the EDP.
But do you routinely think it's a good idea?
Not in this case, but if suppose you have a patient that is acutely ill, transferred, and you don't know what you're dealing with, it's nothing wrong to have a Swan, but I think as long as you know your EDP, you should be okay. You don't need a Swan GANs catheter.
Right. As a part of the PROTECT trial, it was mandatory, but in the clinical life, we learned it. Venous puncture, unless needed, don't do it, because that is telltale or predisposed for vascular complications. So that yes, if it is necessary, we do it, but if it's not necessary, then we don't do it. Now this patient, blood pressure is 60 or 80, 90, I would put a Swan. Patient's blood pressure is 140, I would not put a Swan.
So you already have augmentation of 2.3 liters there?
They're gradually going up over a period of a couple of minutes, they will go up to P8. You start with P2, go to P8.
Already. And what is the
already P8. Now? How much did you get?
Wow. Wow, that's quick. All right, while you get ready, put your guide catheter. I'm just going to complete our quickly. Any other point you want to say on this?
Samin, leave some time today. Yeah. I have a set of outstanding questions submitted to me by Dr. Masahiko Satoda, which I'll continue asking. And let me throw the first one to you. I'll quote it exactly as he's written to me. Is it possible to keep the cardiac output enough to keep the patient awake in case of cardiac arrest during Impella supported PCI?
Well, I mean, yeah, once you're 2.5 liter of cardiac output, yes. Answer to that is yes.
Excellent. The second question is asked is the aggressive statin pre-treatment before the elective PCI helpful for preventing no reflow, slow flow after rotablation? If so, how long would the statin be given? Just the day of PCI or 5 to 7 days pre-treatment? Yeah,
that's a very good point, because Armida, the trial recently with the high dose statin being 80 milligram of torvastatin, Armida 5 now, actually have evaluated, and there are some other data that pre-procedure high dose statin decrease CK release. Now, in there, the procedural complications were not different, but it basically causes less CK release, probably because of some interaction of the plaque and the distal embolism and so. But the data have been that it is associated with lower CKMB release, because part of that probably is the pleiotropic effect and the inflammation, and therefore it should be given. Now, question is, what is the minimum dose? It is the day before 80 milligram. Some studies have given up to 1 week, but about I would say the 24 hour before is completely fine. But I think we'll probably come down to the same, that if you give it a few hours before, it will be good enough. Just same thing happened with the N-acetylcysteine. Remember, N-acetylcysteine required 2 doses before the contrast exposure in the earlier trial of the TAPL and so. But then what we do now? We said, okay, increase the dose, make it 1200 milligram and give it on the day of procedure. So now all trials of N-acetylcysteine are given 1200 milligram that morning. Although the trials, recent trial, ACT trial showed no benefit, but basically I think will happen because it's very inconvenient to give statin day before. Almost every patient is on statin now. The question comes is, by giving a high dose, knowing the patient's already on statin, giving a 80 milligram. Actually, it's so interesting that we are in process of making the protocol change at Mount Sinai, because we work with the protocol that very soon we'll have the incorporate that if patient is not taking 80 milligram of statin or Crestor 40 milligram, I mean rosuvastatin 40 milligram or torvastatin 80 milligram, as you know, 80 milligram simvastatin has been, FDA has just said we should not be using it. And now torvastatin becoming generic will be much easier, so that those are the 2 high dose statin, the data we have, so that we probably will have a protocol soon which will incorporate that if patients are not on high dose statin, that give on arrival into Mount Sinai Cath Lab 80 milligram. So that will be probably same day of procedure, not necessarily the day before.
Excellent. Anu, what are you doing at the moment? Is that a 7 French XP guide?
Yeah, we have a 7 French system. Right. We just went with a VL. This is the same thing. I think if you have a long sheath, what happens, since it takes out majority of the tortuosity, we went with a VL35, which normally could have been the right for this particular patient, but we had to go with a smaller guy, which was VL30, which we have been able to cannulate the left main, and the same in elderly patients, his creatinine is 1.5. What we would do is we will never not take another guide shot, just use our diagnostic shot and start wiring this vessel.
Good. So now, because of this calcification, we felt the proximal part of the calcium. Actually, the second lesion, which is the tightest, has a mild calcium, is the proximal quite a bit tight disease in the diagonal. So they're going to put a rota and we'll do a 1.75 bar. Meanwhile, I'll just take 3 minutes and I complete the second part of our discussion today. If we can go back to the slide while they're getting ready for the rota ablation, is the issue about stent thrombosis after drug-eluting stent of the various DES. Now, as you know, the DES is a system. It's not a stent. It's a system, and system consists of the mechanical engineering, which is the stent, then the polymer, which is the matrix, then the duct pharmacology and how it interacts with the vessel. So that drug-eluting stent is a system, and therefore what is the various component have a different feel or different reaction, and these are the 4 of the stents. Now second generation stents, basically 2 important things: thinner struts, thinner polymer. Purpose: better endothelialization, and that actually had been shown, the data by Renu Virmani in JAC 2 years ago, that the BMS and everolimus eluting stent, kind of their healing process is similar. So you are saying the DES has a similar healing like a bare metal, and endothelial is functional as measured by the VEGF production. So clearly seems to be that experimental data shows that the everolimus eluting stent is very does the very good in terms of the endothelialization and rapid healing of the stent. Now we also know there are various factors in the stent thrombosis: incomplete endothelialization, antiplatelet therapy disruption, and so are very important. Besides that, you need to get a good results of the stent expansion and so that and stent thrombosis continues over the life of the stent. It's not only 1 year, 2 years in life. We learned that with the early data of the first generation, that even after 1 year, there was 0.6% per year late stent thrombosis. With the second generation, with the Endeavor data showed that yes, after 1 year, the second generation stent no longer 0.6%, maybe 0.1%. Similar, now we actually have the 5 randomized trial comparing various stents with the Xience V everolimus eluting stent in the sort out 4 with the cipher, in the lesson 1 with the cipher, compare with the Texas Liberty, Resolute in Resolute all-comer trial, and split 4 with Texas. You can see consistently that stent thrombosis from various time period of 9 months to 3 years is 0.5% with Xience V, which while this number goes up anywhere from 1 to 3% by other the competing stents. So that basically seems to be that drug-eluting stent with the Xience V, with the everolimus combination of the stent strut, the polymer and the drug as a winning combination, and of course interruption in real life as a very low stent thrombosis. Towards that field, we know that bioabsorbable stents are coming, and so far we have the bioabsorbable absorb A and B trial, which actually has shown over 120 patients there has been a no stent thrombosis, so that there will be additional advantage of the bioabsorbable stent in that field. With that note, I'll ask one of my associate, my fellow actually, and of course with George Dangas, the Usman Babar, they actually did some analysis, and will give you 5 slides, and he's going to talk about that what it was. It was a late breaking trial in SKY as well as in the Euro PCR of impact of the everolimus eluting stent on stent thrombosis. There were Usman, if you can tell us
Yes.
what did you find and what kind of analysis you did?
Well, thank you, Dr. Sharma. In the interest of time, I'll go through this pretty quickly. This was a study, as you mentioned, that we undertook. This analysis involved, again, the existing 13 randomized trials. In all trials, the everolimus-eluting stent was compared to a non-everolimus-eluting drug-eluting stent. These included mostly against paclitaxel and the sirolimus-eluting stent, with one trial using zotorolimus. We had 13 trials, 17,000 patients. Follow-up was right at about 2 years at 22 months, and the results were quite striking and consistent. These are the results for stent thrombosis. You can see at the bottom there that there was an approximately 40% reduction in stent thrombosis, pretty consistent across all trials, which was highly significant. For target vessel revascularization, the result was less, about 20% reduction in TVR, and again, myocardial infarction reduced by similar, about 20%. And then we also evaluated whether or not the results varied by certain strata. And for each endpoint, stent thrombosis, TVR, and MI, we found, in fact, that the results were consistent irrespective of clopidogrel duration use, irrespective of the follow-up time across trials. We did find that the results were most accentuated against trials using the paclitaxel stent. They were intermediate against the zotorolimus-eluting stent, and the results were least so against the sirolimus-eluting stents.
Yeah. So that basically, therefore, it basically sums it up. That seems to be at present, based on the data, the everolimus-eluting DES data are very supportive in terms of the benefit in all ways. And this paper actually has been accepted for publication in JACC and should be coming out in September or October.
Yeah, it should be coming in the next one.
Yeah, in next 2 months, so that we'll have a more detail of.
Usman, excellent job. I can see that amongst other things, one of the things you've learned from Samin is how to make a 12-minute presentation in 2 minutes.
All right. Okay. Let's go now.
Anu, what is your progress?
Yeah, I think we have the Impella in the system. It's doing good job. We have wired the vessel with the Rota wire directly, and we have actually, though we are selected for 1.5 bar because 1.75.
Then I changed it to 1.5.
Okay.
Yeah, 1.75. Initially we were thinking whether 1.5 or 1.75. I felt that 1.75 will be all right because of the good lumen and short segment. Yeah.
Now we wanted to do the diag also.
Yeah, we have 1.5 bar for the diag. Good, keep going. Now go with the steps we've said already.
Yeah, so we're just going to go in with the.
Samin, as you use more of the FFR in your cases, are you often noticing downgrading of the syntax score after using FFR?
Well, I mean, actually, that's a great point. Partly because that, as you remember in the FAME trial, the trial of the 2 and 3 vessel disease, that after anatomical multi-vessel disease, that almost 11% became no disease, 0. And about 16% became single vessel disease. Though clearly that physiological disease is different than anatomical, that if we really follow that trend between the FFR guided, but I would say those cases are borderline. If you ask me that has FFR really made a decision in terms of I would not have done the TCI, because most of the cases which we have like this may take away maybe one lesion, like should you do a proximal lesion or not, that maybe in my opinion could be a questionable, but most cases which are referred at present to our system, that they would see 1.75 bar went very easy. And then after it is done, you go to this also, right?
Done.
Yeah, policy, yeah. And then once you are done, you just polish it. And this is what we learned. One single ablation, and it just really helps to subsequent stent expansion. And that too I say.
Samin, something very important here. How is the patient tolerating the rotablation?
Yeah. The patient, right now, actually, it went quite easy. I think the time will come when we are ready to put a LAD diagonal bifurcation intervention in equation. So that at this time, the question comes is that do we treat the distal by the stent and then we come back to the diagonal intervention? And what's your plan?
That if we had to look, if you see that I think diag
it's very
calcific diagonal and moderate disease of the LAD. Ideally, I think in this case, it's nothing wrong in doing a rotational atherectomy of the diag. but you may have to change the burst size to 1.5 bar.
Good. So let's go. We go over the wire, change it to because Rota wire will have a tough time to go into the diagonal. So they will go with the same fine cross here.
Samin, you think IVUS would have helped you in any way, in particularly for the
I would say that for IVUS believers maybe, but this kind of case that for do you need to do a Rota ablation? Maybe if I had to say, IVUS would have said maybe you don't need to do Rota ablation.
One of the reasons I asked you about IVUS, I am going back to Dr. Satoda's questions. Here is his specific questions. What is Dr. Sharma's exact definition of vessel diameter on IVUS? External elastic membrane to external elastic membrane, or
minus, yeah, no, that's it, because that's the only way you can calculate. External elastic membrane minus 0.5. So that's my definition, that you have a 4 millimeter from EEM from top to bottom, therefore the vessel size is 3.5. Because that is where people get into trouble. You have a 4 and you put a 4 millimeter stent, and now you have a lot of bulge. So that therefore, to me, whatever comes out from your EEM minus 0.5 is my, again, I don't want to be say any that I'm authority in the IVUS, but anytime if we are checking and we are using IVUS in our equation, our goal and stent size and design is basically becomes that we are going to make it a 0.5 lower than what the size comes out by the EEM.
Anu, tell me, how much do you think would have been the struggle had you tried crossing the diagonal with the Rota wire?
Rota wire would have been a major struggle, because if no, look at this. You see, even with the glide coated fielder wire, I did have some it took us me few seconds to get into the diagonal. If that wire has some issue, then Rota wire would not have been an easy one to get into the diagonal. And this is an important thing that I think as interventionalists we need to know when we can do Rota of now wiring the LAD. We knew that we could do it with the Rota wire, and we know diagonal we cannot. So this kind of things you need to predict and be ready and do those steps the way you think it's going to happen, rather than start trying thinking that yes, I can do this wire with the Rota wire and try to do it, and what will happen is you will raise a little flap, and that's the end of story.
And see this one, see that diagonal is very crooked. You just lift one plaque in that diagonal, the diagonal is closed, and your procedure now from elective will become urgent. Because that is such a, let me just show this, but that's a very complex, just 1 second.
Yeah.
Here, sorry. Look at this one.
Yeah.
So just because of that, it's not that whether you could do it or not. So clearly we have very enthusiastic fellows and they will try it. And if I come in and they are trying with this wire, first thing I say, become my assistant now. You're no longer the primary operator. Reason is not that you could do it. The point is the risks are a little high. You may do it, but the risks are definitely high, and therefore do what makes sense. Now, LAD, yes, do a Rota directly, but the diagonal, because the wire is not that user friendly. Now, we can, the Boston Scientific does the work and change the wire, makes it a better wire, yes, then we will do it.
I also thought that is precisely the wisdom of downsizing the burst size for the diagonal.
Absolutely.
Anu, what is your anticoagulant strategy here?
We have AngioMax with the ACT of 311. I think we have half bolus. Make it.
The patient was already on clopidogrel.
Yeah.
Did we test him? Although again,
no,
in an elective setting, it doesn't matter. But
half bolus.
Yeah, but even if it is less inhibited in 80 years of age with the CVA, clearly that we are not going to change therapy anyway, even if somebody is non-responder. And we learned that even if they are non-responder, you can make the double dose, 150 milligram daily, but that doesn't help. So that in this particular case, practical utility of testing is not there. So it was not done, rightly so. I know many of our nurses are very much fixated of doing, we actually were very much fixated because we taught everybody that in complex cases, you should do it. But at the same time, that's the protocol, and we change our protocol now that unless clinically indicated or patient is acute coronary syndrome, when we think there may be an issue of the non-response, those cases are the only one we will use the test on the Acumetrics Verify assay now.
Okay. I mean, with so much expansion of Impella and the larger of the balloon pumps, any cases left where the tandem heart still helps?
Well, I would say somebody which we need it and they have a LV thrombus and aortic stenosis, that will be. But I can tell you none of those cases we have found. The reason is that we actually have few left main and AS. We have done a balloon valvuloplasty, and then we use the, then you can use your tandem heart and so that yes, it not be, but I'm sure it has its role. Some people do use it. We have not used. We have used actually in a setting of patients. Pull back a little bit.
Well, to me, just the ease of use is such a.
That's the key. Yeah. Go.
Wire.
Yeah. The wire is quite down, so I'm going to pull back the wire a little bit. Yeah.
That's quite a sharp angle there.
Yeah.
So just a slow pecking motion there.
Yeah.
That is where I will need the most support, not for the LAD yet.
Yeah, but also I hope the viewers can appreciate the totally different skill sets in performing the rotational ablation of the LAD and this diagonal.
Nothing is not connected, not moving at all.
Okay. Yeah. So basically, we advance the bar, and during that process, let's load it up again. Let me do it quickly. Bro, I can tell you, I have seen twice the snap of this connection. Huh?
Come out. It's obvious. Okay.
Just 1 second.
No, that's not the thing. See, it's not snapped well. You cannot.
Yeah, even despite going completely. Get a new 1 point.
Get a new bar.
New bar. Yeah. Just see that connection is snap. No, connection is snap. That's okay. I will take a new 1.5 bar.
I'm going to take this out.
Yeah.
So Samin, let's say if somebody did not feel comfortable doing rotational ablation there, would you use a cutting balloon then?
Yeah. Just go manually now. Fine. No. Just take it out. Yes, but I think the cutting balloon will have a very tough time to make a turn. We can try that, although
no, I think you should. I want to persist with your strategy to use rotational ablation so that we can see where exactly was the issue.
Yeah.
So, Samir, so what happens is this is a very important feel the operator should have. Whenever you are moving the knob, you got to make sure your burr moves with the knob, and that's what I was not feeling, and I knew there is a disconnect between the burr and the knob.
Excellent, and which is what I want to see. How is that eliminated with the new burr?
And then basically what happened, there is a very nice socket which goes in, but somehow that the socket broke down. After the connection, you had to try to see, you cannot separate that end which we saw, but then subsequently now actually the whole the socket snapped, and that really caused this issue. And right now the diagonal, because of the angle, as you see, it's the close, very decreased flow.
The flow is there.
Ready with the speed?
Yeah. It's become very thing. Ready? We did no.
Go. Done. Go. Yep. Guide need to come in a little bit. Yeah. Good. Very good. Guide need to come in. Good. Very good. There is another wire lying on the field. Good. Take it out. Okay. Same steps. Take the tension out.
Okay,
Yep.
so clearly that was the problem. Anu, excellent job with the,
I think we should not go any further, right?
We don't need to
yeah,
go.
you don't need to
There's
problem.
a lot of disease in the diagonal. We are just treating the ostium.
The further down we leave it. Okay, we're coming out.
Anu, just to make your task easier, you have less than 7 minutes to finish the case now.
Okay. Give me the run through for the LED. So you saw the other thing also, you cannot leave any wire in the main branch when you are doing the rota of the side branch.
Right.
So if there was some issue with the main branch after rotational atherectomy, and you think we cannot take out the wire from the main branch, then you cannot do the rotational atherectomy of the side branch.
Anu,
These are very important points.
did you pre-close the Impella?
Yeah,
here?
we did pre-close Impella. Actually, if you see, there's some dissection of the LED.
Yeah, that should not be too surprising, or although crossing that with the wire is a little more,
And we have the fielder wire.
yeah.
Good. And the diagonal still needs some extra work. So what we're going to use, we'll use a Angiosculpt 3O. It's a good size vessel. 3O or 10 Angiosculpt. To open it, could use a cutting balloon, but let's try. Angiosculpt people do ask all the time, how is the Angiosculpt? And I think this will tell us clearly.
Well, there were also some very nice angiosculpt cases during
Why
the
don't we
symposium.
just do high pressure balloon and leave it? No need for Angiosculpt, no?
Get that wire. Okay. Now first we want to.
Let's take care of the LED.
Okay. We are going to take care of the LED. Balloon is we have 275. Okay.
And what should be, one
thing.
stent or two stent?
Yeah.
Can you do one
there.
stent?
This will need two stents. Okay.
Can you put one long stent from there to there?
Go. Yep.
So, Anu, you're putting a 275 balloon there?
Yeah, distal LED props.
Got it, got it.
Yeah,
And
one stent and be done with this guy. Okay. Now we put multiple stents. We are just thinking about the stent strategy, two stent or one long stent.
well, I kind of agree with your strategy too, one long one. Just
Yeah.
prepare the vessel here, and Samin, you'll have to do some modification of your slides.
No.
I noticed now with Cordis coming out of the field, the SCS component probably disappears.
Disappear. That's it. There's no longer competition.
You know.
Unbelievable. I mean, what happened to J&J, the leader in the field?
3.0.
Yeah.
No, this is 275.
Yeah, but it should have been a little bigger. But that's
3.0.
fine. This is a short. Just 1 second.
38 or
clearly.
third? Yeah. I think 3.038, right?
Okay.
So your,
Approximately we can dilate it.
Samin, how would, let's say, a busy practice like yours, one of the largest PCI volumes in the country and in the world, how would you be affected by the removal of such a major company out of the field?
I would say that actually what Xience did, we didn't do much. That the cipher, the use in last few years has been less than 2%. And in the country, I know it was about 6 to 8%. Out of the US, actually, there is still quite a bit of cipher use. But just because of I would say I would have been very much affected if it would have come out back in 2004, 5 and so.
50,
But
20,
now,
20,
because we have such a good stents, others, and now issue about the radial strength, which is some cases of cobalt chromium is the issue, and this calcific case and this particular, because of the long lesion length, we are using here 3038 iron. You know, iron is the new stent of Boston Scientific, paclitaxel coated with a thin struts, but it's a platinum chromium.
Good.
2 millimeter more, no?
No, I think
Yeah.
good.
You need to go to the septal. Okay, we're taking a picture. See, one stent will cover all. Yeah,
Pull back.
beautiful. Yeah, we can pull back a few
Yeah, I
millimeters
thought
if you need
come
to,
back
but
a little bit, no?
Yeah, 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 yep.
So you think this is going to eliminate all the long taxes?
Yeah, definitely long taxes, and part of that also happens that many times our inclination use one stent versus two, and it's a less compliant balloon compared to our Promus and Xience, that you can go to a 14-16 atmosphere.
So you probably don't need to post-dilate most of these?
Yeah, maybe proximal area, because proximal vessel is 3.5. So that just do a 30-second inflation, and now on the right side we do have a Xience. So the question comes that does it matter you have a one drug on one side versus other? And I think there has been a lot of reports of the stent combinations, and probably it does not matter that as long as patients taking a good antiplatelet therapy, that what stent combination you have used. Okay, take a picture before you come out.
Let's do it.
Huh? Picture?
No, let's do the high pressure. Let's do it.
Okay.
I bet you, Anu, in your mind you're conserving dye.
Yeah, exactly.
Yeah.
You know what I'm thinking.
The proximal area, because the vessel is 3.5, so that will post dilate and then take a picture. Yeah. And then also very interesting, most of the our fluoroscopy equipment now can save your fluoro. So many times people give a little dye to see. Make sure you hit the fluoro save button, so that now therefore now you don't need to give another dye to do the cine. So fluoro save button with the new equipment helpful to conserve dye, and so that use that feature liberally. Many labs have it, but many people don't know it.
Yeah,
Okay,
that's
This is a 3.5.
It's a 3.5, 16?
Yeah, 16.
Yeah.
Good. Yeah.
it's a little unusual. I normally think it's a good practice going from distal to proximal. How is it you did the other way around there?
I think the distal we are not going to
Touch at all?
touch it at all.
Okay.
Yeah, this bend will do it, but
The
this
mid
will go
portion.
at 14 now, because this is a 3.5.
Got it.
And the vessel further down is probably just 3.0. So the distal portion we are just not going to do anything.
That's a smart strategy.
Yeah, it actually, because it has expanded valve. Now, if you did not do the rotational atherectomy, then I would say the post dilatation in the entire segment was a must. So this one, I am just going to show that feature that we are going to come back. Now we are going to show a little dye, okay? On the fluoro. Not on cine.
Okay.
And well,
Looking
fluoro
good.
save.
Yeah. And then now you have the fluoro save. The fluoro has been saved. Now, basically, what do you want to do? Now, play, replay.
No. You
Good.
lost.
Fine. Minus?
You pressed the.
No.
Yeah, but that's.
Yeah, right there.
Yeah, I think the LED looks good.
And not only that, you know the fluoro save will give you 1/3 of radiation of your cine. Okay, and now ready for the ostial, little modification further. Let's put the wire into the side branch.
Yeah, that ostium there requires
Need
some
little
attention
one.
still.
Yeah.
So Anu, thinking further on in this case, you would remove the Impella device post-procedure in the cath lab?
Yes, yes.
Is
What
that
is
how
going to
you're doing?
happen is, I think as we are finishing the diagonal workup, actually our tech Pablo is already making some signs to me saying that should he start weaning the.
And what was your answer?
Not yet.
Okay. So I think a smart idea. Let's get a better progression of the case with the
more
diagonal.
symptomatic with the diagonal interval whenever we do diag.
Right. So what would you do before you're removing the Impella? Do you stop the angiomax or continue that?
No, continue. I mean, in this situation, since it's already been preloaded, I think we should not have any issue. We are going to stop the angiomax. They will take the Impella out, but more important, stopping angiomax in this situation is for the groin closure.
Got it.
See, the ostium of the diag is not exactly what we predict it is.
Okay.
It's
Now
a very
we got
sharp
it.
angle.
Yeah.
Very small amount of dye.
Samin, looking forward at the Impella device, what do you think, what further improvements could be possible besides reducing the size?
The size, that's it. To me, I think that's what basically needs. I know we can go beyond 2.5 liter. You need a bigger one with 5, with more of a surgical cut down and bigger size. I think that to me and a lot of other advances which already have been done are quite remarkable, and particularly with the quick setup and the console telling you that where your the distal or proximal ports are, whether you are in the aorta, ventricle, right position, so the color code. So we don't, no need to think any differently, just go with the color codes now.
What's the balloon size, this one?
Go.
Bag is not that big.
No, look at it, on top. On the top. Osteo.
So what is the disparity in your thought process? Samin thinks it's a 3-0.
Yeah, one, since we already have done rotational atherectomy, I'm a little concerned about going a high pressure balloon, means a higher size balloon for this osteal diag. I would have gone with the 2.5 or even a 2.75.
2.75. And so we have a 3-0 there?
Yeah, it's a 3-0. And you saw that despite that angulation, angiosculpt went quite easy. And we're just going to go to a low pressure to see, take Anuj, because here I want to this combine that get a good result in the diagonal, because this age, if we can, despite a large vessel, if we can come out with the good results of the plaque modification and stent across that area of the LAD, will be good enough and not get any crazy further. Pull back a little bit.
Having done rotational atherectomy of the side branch, I think high pressure balloon dilatation of this ostium was probably sufficient.
Yeah, that is true. I mean, I would say nothing wrong in that.
Now we are talking about the cost of this cutting balloon.
Yeah. Angiosculpt. Okay, let's come back in the guide and we take a picture and then put we are 5 minutes ahead.
Clearly because of the size of the diagonal, you are proceeding with the 2-stent strategy there, no?
Yep. Or the question is, do you want to put a stent, or even that area of the LAD, you have done the rota, moderate lesion there, or you want to just leave it?
I think it needs to be stented.
Not the diagonal, means the LAD you mean?
Yeah.
Okay, let's see. Ready?
I
don't know. Looks very good there.
Yeah, leave it alone.
Very good there. Yeah.
With that age, excellent results of rest of it. If it's okay with everyone, I am completely fine to stop it here.
Anu, what do you think? What is your decision here?
I just feel that we should go with the balloon and leave a prolonged inflation at that ostial diag.
What do you think? What do you think about the LAD segment after the stent?
I think LAD segment will be okay. We just give some vasodilators. We give some vasodilators. It will perk up. We just have to, since our plan is to not to stent the diag, just leave a prolonged balloon inflation, 90 seconds, couple of minutes there, so that we get that we have cracked the lesion. We did rotational atherectomy, cracked the lesion. The goal is any little micro dissections that we have created is nicely patched up with a long balloon inflation.
Excellent. No problem with that strategy. Samin, what is your take-home message here?
So we just get to the last point, and with this complex case,
50.
we are able to do in all that LV support by Impella Recover 2.5 has shown to improve overall procedural outcomes and complete revascularization in high-risk PCI. Hence, is routinely recommended in high-risk PCI with the lower ejection fraction. So I think clearly we have solid data to support in favor of Impella at present in these cases. Second, there is strong data to support the superiority of everolimus eluting stent, Xience V Promus, over other DES in reducing early and late stent thrombosis. That by the meta-analysis late-breaking trial with George Dangas and Usman Babar. Procedural technical details and the plaque modification are essential in management of complex PCI to achieve good procedural results and minimize stent thrombosis, and that I can say that is what is all about, that we have so low incidence of stent thrombosis because of this plaque modification. With that note, I think our
Anu, I want to take your final word on this case. I can tell you, to me, the best illustration was how to navigate the diseased anatomy.
Yeah, I think in this case, if I could have predicted what could have been a challenge was definitely how to get the Impella negotiation through that calcific and tortuous iliac, which we already showed. and how do we handle this kind of a bifurcation where you have moderate disease in the LAD Medina, which would be 001, where you have ostial calcific diagonal disease, do rotational atherectomy, good balloon result because of the age, and leave the rest of the vessel alone. I think these two probably are the take-home points in this particular case. And this complexity of, as you see, when we are doing rotational atherectomy of the diag is where the patient did have some EKG changes, and we could have done this complex case in this elderly patient with that EF since we have this LV assist device. And that is what it has clearly shown, that when you need it is when your EF probably less than 30. More important also, if there is underlying mitral regurgitation, this device really helps you to do the case, means complete the case, not thinking about hemodynamic compromise that is going to happen during the complex situation. Another important point that I want to make, this is our last month. Our 8 fellows will be graduating. I have Sumit, who is next to me, and if you have seen Impella insertion, majority of the wiring and most of the case he has done himself. And
look,
that is
he did not appear like a fellow. He was an absolute pro. Sumit, excellent job. We've enjoyed watching you over many cases.
And yeah, I'm very proud that our fellows, actually today I have Dr. Sharma as my assistant, but otherwise this case I will do with my fellows. All kind of complex cases we do with them, and at this stage they know exactly what we want, and will be happy that we have this great team of these fellows. We have trained them well. We are proud that they will be taking the Mount Sinai flag and give us a good name.
Anu,
which one?
Excellent job. Congratulations to your fellows completing. I also want to thank Dr. Satoda for his outstanding questions and to keeping us involved. Please send us our request. We'll be happy to send you our all 24 archived cases. We'll end the show here. See you next time, session 25 on July the 19th.